If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we're going to go through the NICE guideline on chronic heart failure, which was last updated in September 2025. Today's episode focuses on the additional management of heart failure. If you haven't already, I recommend that you check the previous episodes where we covered heart failure diagnosis and the drug management of the different subtypes of heart failure. Right, let's jump into it. And as we have just said, today we're going to focus on the additional management of heart failure. Now let's start by looking at how to initiate and monitor medication use. When tailoring treatment, we should use a person's medical history, frailty status, and prognosis to decide which specific medicine combinations to use and how to introduce them. In primary care, we should seek the advice from a heart failure specialist before starting someone on an angiotensin receptor neprilysin inhibitor, that is, sacubitril/valsartan. Before prescribing an ACE inhibitor, ARB, angiotensin receptor neprilysin inhibitor, or mineralocorticoid receptor antagonist, we will check renal function and electrolytes. Once these drugs have been started, we should check renal function and electrolytes 1 to 2 weeks after starting treatment, 1 to 2 weeks after each dose increment, every 3 to 6 months once the maximum tolerated dose has been established, and at any time renal function may be compromised. If the serum creatinine increases by more than 50% or potassium rises above 5.5 millimoles per liter, we will follow local guidelines. We will measure blood pressure or ask the person to measure it themselves before and after each dose increment. For people with symptoms of postural hypotension, we will measure blood pressure according to the NICE hypertension guideline, which essentially recommends ideally checking the initial blood pressure in the supine position and then again after standing for at least 1 minute in order to check for a drop in systolic blood pressure of 20 millimeters of mercury or more. Although checking the blood pressure in a seated position can also be acceptable, we need to remember that measuring blood pressure from sitting to standing may miss some cases of postural hypotension, especially in older or frail people, and that by measuring from lying to standing is more accurate for detecting a significant postural drop. When prescribing beta blockers, we should not withhold treatment solely because of age or the presence of peripheral vascular disease, erectile dysfunction, diabetes, interstitial pulmonary disease, or COPD. We will assess heart rhythm, heart rate, and conduction abnormalities using a 12-lead ECG before deciding whether to prescribe a beta blocker. We will not offer a beta blocker to people with second-degree or third-degree heart block, who do not have a pacemaker, or to those with bradycardia, that is, a heart rate below 50 beats per minute. We will assess heart rate and clinical status after each beta blocker dose increment, and for people with symptoms and bradycardia, we will consider repeating a 12-lead ECG after each dose increment. For digoxin, we will not routinely monitor serum digoxin concentrations, but we should be aware that the digoxin level measured within 8 to 12 hours of the last dose may help confirm toxicity or non-adherence. But we must interpret results in a clinical context, since toxicity may occur even when the concentration is within the therapeutic range. Now let us move on to clinical review. We will monitor all people with heart failure and provide a clinical general assessment, including cardiac rhythm, a medication review, checking for any necessary changes or side effects, an assessment of renal function, and measurement of iron status and hemoglobin. This is just a very minimum. Additionally, we should provide more detailed monitoring for people with significant comorbidities, co-prescribed medications, or recent deterioration. The frequency of monitoring will depend on the clinical situation and the stability of the patient's condition. If the clinical condition or medication has changed, we should monitor the patient more frequently, from days to every 2 weeks. For stable people with proven heart failure, we will monitor at least every 6 months. For people under 75 years old with heart failure with reduced ejection fraction and normal renal function, that is, an eGFR greater than 60, we can consider measuring NT-proBNP levels to monitor and optimize treatment. Now let's look at other treatments and advice relevant to all types of heart failure. We will use diuretics to relieve congestive symptoms and fluid retention, and we will titrate the dose up or down as needed, always using the lowest effective dose. Amiodarone should be started under specialist supervision, and we will review the need to continue it every 6 months. And at each review, we will check liver and thyroid function tests and assess for side effects. For people with heart failure and atrial fibrillation, we will follow the NICE recommendations on anticoagulation for stroke prevention. For people in sinus rhythm, we will consider anticoagulation if there is a history of thromboembolism, left ventricular aneurysm, or intracardiac thrombus. We should offer annual influenza vaccination and a one-time pneumococcal vaccination to all people with heart failure. For people of childbearing potential, we should discuss contraception and pregnancy. If pregnancy is being contemplated or it occurs, we will seek specialist advice from both cardiology and obstetrics. We will not routinely advise people with heart failure to restrict sodium or fluid intake. However, we should ask about salt and fluid consumption and provide advice when necessary, for example, by restricting fluids for dilutional hyponatremia or by reducing intake for those with high salt or fluid consumption. Additionally, we will advise people to avoid salt substitutes that contain potassium in order to minimize the risk of hyperkalemia. In terms of air travel, we can advise that it will be possible for most people depending on their clinical condition at the time. Regarding driving, we will simply follow DVLA guidelines. We should offer people with heart failure a personalized, exercise-based cardiac rehabilitation program, which should include psychological and educational components. Finally, in terms of palliative care, we should not offer long-term home oxygen therapy solely for the advanced heart failure. However, we should be aware that long-term oxygen may be offered for comorbidities, such as COPD. If symptoms are worsening despite optimal specialist treatment, we will refer to palliative care in discussion with the heart failure multidisciplinary team. So that is it, a review of the additional management of heart failure. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.